Good evening, everybody, and welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Chirag from the University of Cincinnati, Ohio, United States. After completing his residency in India, Dr. Berry moved to the United States, where he completed his fellowships at the Medical College of Wisconsin and also spine fellowships at the Massachusetts General Hospital, Boston, and the Cincinnati Children's Hospital. Currently, he's attending orthopedic surgeon and assistant professor of orthopedic surgery at the University of Cincinnati School of Medicine, Cincinnati, Ohio. So today, it's my great honor to bring back Dr. Chirag for this wonderful live program. Over to you, Chirag.
Thank you, Hitesh. Good morning and good evening, everyone. I'll be talking on OLIF or ATP, that's oblique lumbar interbody fusion or anterior to psoas approach, but with a specific um, attention on including L5S1, which is a very critical portion where it's important that we make sure that we take care of certain complications or avoid certain complications just because L5S1 has a very separate kind of specific kind of a vascular anatomy around it. Let's start off. So as we discussed in the previous talk, going obliquely at levels above L5, you have a wide corridor between your left psoas and your aorta. So you have a wide natural corridor that you can take advantage of. You often don't require a whole lot of retraction of the vessels. And obviously, you often don't require to ligate any of the segmental veins to get a safe approach, especially for interbody fusion. And unlike going through the psoas, you do not require neuromonitoring. You can have complete muscle relaxation, which helps with your approach. You can have, the ribs and the iliac crest don't come in your way. And you can do these approaches without needing an access surgeon most of the time when you're staying above L5. So what happens at L5S1 that makes it so difficult to approach it obliquely? So there is no pre-psoas, a natural corridor between the psoas and the vessels because the vessels are now ligated. They are more laterally positioned and the space between the psoas and the vessels is very limited over here. So you have to work and create this interval and you have to mobilize this vein such that you kind of create that interval over there. Or you could go between the bifurcation as well. So you have to have good amount of experience working next to these large vessels, and often a good idea to take the help of an access surgeon, which may be a general surgeon or a vascular surgeon who may be having good experience with these approaches. There is a higher risk of vascular injuries when L5S1 is included with these oblique approaches. So that is why it's always safer to kind of understand this anatomy better and take help when needed. Transitional anatomy of the lumbosacral junction always creates challenges in these approaches, and that's also something that we're going to address in this talk. So if you're treating only L5S1 and you're trying to look for good anterior approaches, a supine ALIF or anterior lumbar interbody fusion may be a great approach since you are able to go directly under the bifurcation. You have a direct shot at it. You have good visualization of both the L5 and S1 end plates, and you're able to do a good interbody fusion. You can always do it minimally invasive with a small mini open transverse spanning steel incision rather than making a midline incision and trying to create a larger defect in the anterior abdominal wall. But you have the worry of injuring your sympathetic plexus, which is known to cause retrograde ejaculation, especially in younger males. You need to be extremely careful about this. And secondly, a low bifurcation can create an obstacle for this approach, and you may still require some amount of retraction of your left common iliac vein to be able to work in this interval. So this is the left common iliac vein, and you may have to retract this laterally to kind of improve this space, especially when in patients with a low bifurcation um, compared to the lumbosacral junction. So if you're doing multiple levels, and if you're able to do all the levels, including L5S1 in the same single lateral decubitus position, that's a big advantage. You won't have to first do a supine ALIF at L5S1 and then turn the patient to lateral position for the other levels. This way you can just do all your levels in the same lateral decubitus position. Lateral position does have some theoretical advantages. You're getting assisted by gravity in getting the peritoneal sac and the bowel retracted out of your way. So there's a theoretical low risk of paralytic ileus. And of course, this is a versatile approach, and the crest and the ribs don't come in the way, so you can potentially reach all levels between T12 to S1. So three different oblique approaches to L5S1 have been described. The most commonly described technique is the left intra-bifurcation technique, and I'll describe it in the next few slides. And the less commonly described techniques are the left pre-psoas technique, where you're kind of staying within that pre-psoas plane, just continuing inferiorly and staying lateral to the bifurcation. This is the left intra-bifurcation, and this is the left pre-psoas technique. This is how it would look in the axial section taken through the L5S1 disc. So this is the intra-bifurcation. This one is going left pre-psoas. Now the right pre-psoas is a very rare, less described approach, and it requires a right side approach. And you're basically doing an ATP or an OLIF approach at levels above L5 and just continuing inferiorly and staying lateral to this vessel on the right side. It's been described by just 2 or 3 papers so far, but it tends to have a good advantage in certain specific situations. Of course, it requires experience for a right-side approach. So let's start off with describing these techniques. The left intra-bifurcation approach has been commonly described most prominently by Dr. Woods and Dr. Hines in this paper from the Spine Journal in 2017. So this is the patient placed in a right lateral decubitus position with the left side up. And you have to kind of trace your S1 end plate anteriorly and also trace a horizontal line starting from the top of the S1 end plate and then kind of create an oblique incision parallel to your iliac crest here. You have to reach inferior enough so you can reach the L5S1 plane. So this is a left-sided approach. A lot of people are familiar with the ALIF approach. So you're going under the bifurcation with this approach. You have to ligate the median sacral vessels. This is the intraoperative picture when you do this approach. This is taken from the paper by Dr. Woods. So you're exposing the L5S1 disc. This retractor is retracting a left common iliac vein. And this mark is the midline. So you see that you expose a good amount of your left-sided disc over here. So this requires a little bit of orientation because you're going in the oblique anterolateral direction, not a straight supine anterior direction. And you place an ALIF cage. An ALIF cage is different from a lateral cage in that it will have a smaller width, medial lateral width, but a deeper anteroposterior dimension. So unlike a lateral cage where you're placing it through the lateral annulus going into the other side, that will be much more wider in the medial lateral direction, but doesn't have to be that deep in the anteroposterior direction. The main goal with the lateral cage is to reach the strong cortical bone on the lateral edges of the disc. But in the ALIF cage, your main aim is to take down the ALL and do a good amount of lordotic correction. So you're able to do it with a different type shaped cage, and you don't have to go that far laterally, so it can be a narrow cage medial-laterally. The left pre-psoas technique is the second most commonly described technique, most commonly being described by Tenori in 2019. It's a left-side approach, just like the previous one. So the patient is in a right lateral decubitus position with the left side up. So this figure, you have to imagine as if you're going from the left anterolateral direction. So you're seeing your aorta, your left common iliac artery, The vein is kind of partially behind the aorta. You obviously won't see it, but you kind of imagine it. And this is the left common iliac vein that goes under the left common iliac artery and goes in this direction. This is the L4-5 disc. This is the L5-S1 disc. So if you're trying to stay lateral to your bifurcation, you have to realize that you may have to ligate this vein, the iliolumbar vein, to mobilize these left common iliac vessels medially or anteromedially to expose the lateral annulus of your L5-S1 disc. And then you place a lateral cage going from the lateral annulus of the L5-S1 instead of an ALIF cage. Next is the right pre-psoas approach. Again, imagine that this is a schematic diagram of the vessels as if you're going from the right anterolateral technique. So the patient is in the left lateral decubitus position with the right side up, and you're staying lateral to your bifurcation. You're staying lateral to the right common iliac vein over here. And you may have to ligate the right iliolumbar vein, which is also the L5 segmental vein, so you can mobilize these structures medially and be able to expose the lateral annulus of L5-S1. And you can place an L5-S1 lateral cage through this approach. This is the intraoperative picture. This is the right common iliac vein, and this is the L5 segmental vein or the iliolumbar vein. This is being described by Tenori in 2019, and also our recent paper published online a couple of months ago. So let's go and describe the advantages and disadvantages of these three techniques, and then we'll go on to how we choose an approach. So what are the advantages of the left intra-bifurcation approach? So yeah, the ALIF approach to L5-S1 is familiar to a lot of surgeons, and this is just a modification of that approach where the patient is in a lateral decubitus position and you're trying to approach under the bifurcation. So it's very familiar to a lot of surgeons. You can do a complete ALL release because you're taking down your anterior portion of the disc, and that can allow you to really correct your lordosis at L5-S1, place even a hyperlordotic cage with lordosis ranging anywhere from 20 or 24 degrees as well. Now this picture over here is I'm trying to explain here with this oval circle here that the L5-S1 plane is such that if you're going from the back, your incision is going to be much higher, but if you're going from the front, your incision is going to be much lower just to get to the L5-S1 plane. So if you're going to approach the L5-S1 through an oblique incision and you're staying anteriorly or under the bifurcation, your incision has to be far lower on the skin and reaching enough inferiorly to reach the plane of your L5-S1 end plate. Unlike staying in the pre-psoas direction, you can have a smaller incision and that can be much higher as well. So the disadvantages of this left intra-bifurcation approach is that the main one is you require longer oblique incision. Of course, the aponeurotic portion of the external oblique is encountered, which has to be nicely closed at the end to avoid any hernias. Secondly, you have to kind of prepare your L5 end plate with curved instruments such that you might not be able to visualize this L5 inferior end plate. And a lot of this preparation could be blind, especially in patients with a large sacral slope. If there's a large sacral slope, your incision might just not go inferior enough to reach, to kind of visualize this L5 end plate. So this preparation can be blind. Blind preparation is fine, you can still do a good job, but if you over prepare the end plate, you can end up with subsidence, or if you under prepare, you could end up with a pseudoarthrosis. So because your incision is quite lower with this technique, you might require separate incisions for upper lumbar levels. Doing a single incision surgery with this approach can be difficult if you're going up to upper lumbar levels. And then your midline orientation is something that you have to get used to because the midline is going to be more in the corner over here, and you're exposing a lot of the left hemidisc and staying just left to the midline here so that your cage doesn't slip out onto the right side when you place it. So this requires your blade to retract your left common iliac vein much more than you would expect in a supine ALIF. In a supine ALIF, you don't have to retract the vein as much, but in this approach, you will likely have to in a lot of patients. And then you are taking down the entire ALL, which is an advantage because you can correct the lordosis. But at the same time, that's a disadvantage because you will have to kind of place a plate or a screw and washer to kind of prevent any dislodgement because there's nothing anterior to it. So you don't want the cage to get spit out anteriorly. You will have to add that extra piece of hardware to make sure that your cage is well seated. And again, you're not avoiding the risk of injury to the sympathetic plexus with this approach, and you can still have retrograde ejaculation because of that injury in this approach. So let's go to the advantages of the left pre-psoas technique now. So as I described earlier, because your approach is more lateral to your L5S1 disc, your incision can be much higher instead of going far too inferiorly over here, and can be along the skin lines or transversely as well. And that'll make it easy for you to reach multiple lumbar levels instead of just the lower few levels of the lumbar spine. Now, because there's no natural corridor, you have to kind of carefully dissect down and create that corridor. But it's easy to do because you're basically continuing the plane between the psoas and the midline vessels on the left side, which you're normally used to for levels above L5. You're placing a lateral cage through the lateral annulus, so you're able to put a much wider cage to get good amount of support on the lateral portions of the end plates. You can have a short transverse incision like it just described. Now, this approach can be an important intraoperative bailout. Say if you're trying to reach the L5S1 disc with the intra-bifurcation approach, you're having some difficulty because a lot of adhesions with the vein, you cannot retract the vein, you cannot mobilize it. You can explore the left pre-psoas approach within that surgery without having to change anything in terms of positioning and so forth as a bailout, and that might be eventually successful, and that you could avoid having to struggle with adhesions around the vein. Now, of course, when there are advantages, there are some disadvantages as well. So just like in the other approach, you're trying to reach your L5S1 with bent instruments. So you want to go in this direction, kind of have bent instruments so you can scrape out the L5 inferior end plate. So your L5 inferior end plate preparation is mostly blind, and you can under-prepare or over-prepare depending on how aggressive you are. With the normal OLIF or ATP approaches above L5, when you go from the lateral annulus, you have the ability to reach the contralateral annulus and create a blunt rupture or a sharp rupture to create more of a release onto the discs. But when you're doing this left pre-psoas approach on the L5S1 disc, it's advisable not to pierce the contralateral annulus just because you have laterally placed vessels here that could get injured. So you kind of avoid going that deep in as well. So that's a disadvantage. You cannot do an ALL release with a lateral annulotomy. It's going to be difficult just because you cannot see it well. You can do a blunt rupture, but you cannot really do a sharp release of an ALL with this approach. Lastly, you have to often ligate the left iliolumbar vein. And most importantly, the left common iliac vein can be flat and oblique, and sometimes it just appears and sneaks from underneath this artery. And you really have to kind of look at it and recognize it with the color. It has that bluish, dark bluish hue to it. And it can be very difficult to recognize if you're not used to seeing it. But you do have to recognize it so you can avoid an injury to it. Lastly, the left iliolumbar vein can be very, very broad and can be short. So ligating it can be a little bit of a challenge as well to allow mobilization of these vessels. So you have to realize that the aorta is like an inverted Y-shaped bifurcation, but the IVC is more like a lambda-shaped bifurcation. So the left common iliac vein has a lot of long course here going across anteriorly, and some of these anterior osteophytes can really flatten the cross section of the vein, and that's why the vein looks much more flatter on the left side than the right side. So that's a significant disadvantage on the left side. So that's why the right-sided approach can be advantageous. Again, you can use a short transverse incision, and a right-sided approach is usually done for specific indications, like if you've had left-sided surgery, or if you have a concavity of your scoliosis to the right, or if you have certain vascular anomalies that make it difficult to do a left-sided approach, then a right-sided approach is chosen. And in that case, you can even include an easier access to L5S1 as one of the things that would allow you to use this approach over the others. Now, one of the advantages that I've noticed with this approach is that you visualize your IVC and the right common iliac vein throughout the course. And the right common iliac vein tends to have a rounded border, so it's much easier to mobilize. And it has a much vertical course, unlike the left one, which has a flat oblique course. And lastly, the right iliolumbar vein tends to be a little longer and narrower in its caliber, so it's easier to ligate. You want to ligate far away from your large vessel, because if it's too close, sometimes with the negative pressure, the stump can get stuck and you might need a purse string suture around it. You want that length in the iliolumbar vein to ligate safely. Of course, this has disadvantages. You need experience with the right-sided exposures. And because the right-sided oblique corridor between the IVC and the psoas is much narrower, even at upper lumbar levels, you have to kind of create that plane at the upper lumbar levels. Again, it has the disadvantages, all the disadvantages of the left pre-psoas technique, like the using of bent instruments, blind preparation of L5, and inability to do a sharp release of ALL, and so forth. And this approach has to be chosen prior to surgery. You cannot use this approach as a bailout of any other approach. You have to decide preoperatively that you're going to go from the right side, and then be able to do this approach. So you may have to kind of bail out on your L5S1 and do it posteriorly if you're not able to reach it for some reason intraoperatively with this approach. So how do we choose an approach? We have three good approaches, but how do we choose it? I think the major reason why anyone would choose one of these approaches is the personal experience and comfort level. If you're used to one of the three approaches and you've always done it, and your access surgeon is comfortable with it, they've always done it that way, going with that approach would be the major deciding factor. But the goal of this talk is to help you realize that there are multiple approaches and you could potentially have much more safer intervals at other places, and kind of understand the vascular anatomy in that regard. But a lot of the patients can safely undergo these more than one of these approaches. So there's no right or wrong answer as to which approach you choose. It has to be dependent on your personal experience and comfort level, and the specific anatomic situations that your patient has. These situations can be more favorable to one of the three approaches, and so it's important to understand these as well. Most importantly is the bifurcation anatomy or the vascular anatomy. The transitional anatomy of the lumbosacral junction can also create challenges, and that also needs special attention when you choose these approaches. So one of the main things that has been studied is the relationship of L5S1 disc with the left common iliac vessel. This has been studied by Chung in 2017 through this paper in the European Spine Journal. They looked at the axial section of L5S1 and they divided the left hemidisc into three columns, sagittal columns, and they looked at where the left common iliac vein was. So if it is in the lateral third of this left hemidisc, or if there's adequate amount of fat plane underneath it, like you see over here, then it's type 1. And then you can possibly use your left intra-bifurcation approach just because you have a wider interval, or you can safely retract the vein because of the fat plane. But if it's flat and oblique, and if it's adherent to the annulus and it's in the medial 2/3 instead of being in the lateral third of this hemidisc, then approaching to an intra-bifurcation approach can be challenging, and that could have a higher risk of vascular injuries according to this paper. So in those situations, you could explore the pre-psoas approaches rather than the intra-bifurcation approach. So I use a separate method, and I prefer this method of the one that Chung described, just because you don't have to measure any columns. I call it the facet line method, and what it is basically is you draw a parasagittal line through the medial border of your left L5S1 facet joint here, and you trace it anteriorly, and you see how it's related to your left common iliac vein. So here, the line is medial to the left common iliac vein. So I have a wide intra-bifurcation interval, so I can easily use this intra-bifurcation approach. In the second figure over here, this patient, the line is kind of going through the left common iliac vein, and the left common iliac vein hardly has any fat plane underneath it. So I'm going to struggle with an intra-bifurcation approach here. So if I see that this line is not medial to the vein, and the vein is the inner edge of the vein is medial to this line, I would rather explore the possibilities of a left or a right-sided pre-psoas approach rather than taking the risk of an intra-bifurcation approach with a higher risk of vascular injuries. Then comes transitional anatomy. So there are two kinds that we need to worry about: the lumbarized S1 or the sacralized L5. So the lumbarized S1 is the most challenging one. This is an example here. You see that seems to be the S1 segment, but there's a well-formed disc between S1 and S2. And you kind of are in a dilemma whether you should put an interbody cage here at S1, S2 segment or not. So most often you don't have to, and one of the reasons is you could do a CT scan. You could check if the posterior elements at S1, S2 are already fused congenitally, and so you don't need additional fusion. If they're not, even if they're have very low mobility, you could just add more posterior fixation rather than having to do an interbody fusion. If you do have to do an interbody fusion, you want to use one of the oblique approaches. The only approach available for an S1, S2 would be an intra-bifurcation approach, but then you'll have to go very low with your incision because your slope is going to be very high. And most of the time, I would rather just avoid doing this interbody fusion, just do traditional posterior fixation or S2 pedicle screws or iliac fixation, anything to stabilize that segment rather than having to go that deep with an interbody fusion. Now, sacralized L5 is, excuse me, sacralized L5 is a much easier problem to deal with because there is no real L5S1. So this is an example. You see this S1 segment is more square shaped, more shaped like a lumbar vertebra. This is a rudimentary S1, S2 disc here. But this L5S1 disc is behaving more like an L4-5 disc because your bifurcation is much lower. This is the cross section through L5S1. And you can see that the bifurcated left common iliac vein is actually here in the midline rather than close to the psoas here. So that really makes it behave more like an L4-5. You can safely do a pre-psoas approach on the left side without even encountering any vein ligation or any significant retraction of the vessels. So that's an easier problem to treat. So I'm going to go through some examples that will show why I have chosen one of these approaches in different patients. So this is the first case. This is a 58-year-old gentleman who presents with L3 to S1 stenosis. The cross-section through L5S1 shows a wide intra-bifurcation interval. The facet line is far medial to the left common iliac vein. The left common iliac vein has a rounded inner edge. So this tells me that the left intra-bifurcation approach is going to be straightforward. It's going to be a straight shot. And and that's the approach that I ended up using over here. This patient also has a low sacral slope, so my incision doesn't have to be far to inferior, so I can potentially use that same incision to address the 3, 4, and 4, 5 as well. So that's what I did. I placed an ALIF cage at L5S1. I placed a screw and washer to partially cover it to prevent dislodgement. That's my preferred technique, and that may be different. Some people try to put a plate on top of it. Then I've used regular lateral interbody cages at the other level. And posteriorly percutaneous pedicle screw fixation. I did not use neuromonitoring. Patient went home on day 2. He had some transient left groin pain, which improved in 2 weeks. This is the second case. 69-year-old gentleman has a very large scoliosis in the lumbar spine with concavity towards the left side. Now, this patient had transitional anatomy like a sacralized L5, such that the L5S1 behaved more like an L4-5. And you can see in the cross section that your left common iliac vein is actually in the midline and the facet line is far lateral to that vein. So a left pre-psoas technique was fairly straightforward in this patient. I did this in a staged approach with L1 to S1 ATP as stage 1 and T11 to S1 with iliac fixation as stage 2. So this is how it ended up looking. I was able to use a single transverse skin line incision from the concavity that's from the left side. And because I was using the left pre-psoas approach, that incision was a little higher than what I would have had to use with the intra-bifurcation approach. I was able to put lateral cages throughout between L1 to S1. I did not encounter the left iliolumbar vein, and there was no need for retraction of the left common iliac vein. The artery needed some retraction. Of course, the arteries have thicker walls. They're much more easily retractable. I did not use neuromonitoring for stage 1, but I used it for stage 2 when I placed the percutaneous pedicle screws. The patient went home on day 6. He did not have any approach-related complications. This is the third case, a 72-year-old gentleman. He kind of has degenerative stenosis at all the levels, but most severe between L3 to S1. This patient, if you look at his L5S1 axis section, he hardly has any intra-bifurcation interval. The facet line was going through the left common iliac vein, which is flat and oblique. So any approach from the left side would have been challenging here. Going intra-bifurcation, a very narrow intra-bifurcation approach, and was fairly medial. And because it's flat and oblique, the left pre-psoas technique would also have been very challenging because it's flat and oblique, less fat plane underneath it. On the right side, however, there seems to be some wide corridor and some fat plane underneath this right common iliac vein. So I chose the right pre-psoas technique in this approach, in this patient. This is how it ended up looking. I was able to use a single transverse skin line incision. I placed lateral cages at all 3 levels. The right iliolumbar vein or the L5 segmental vein needed ligation and was able to safely retract or mobilize the right common iliac vein. And percutaneous pedicle screws from the back, no neuromonitoring. Patient went home on day 2 without any approach-related complications. So these are the examples. Now, lastly, the complications. So I've brought up these papers which have a good number of patients that had L5S1 included. Of course, they all use different techniques. One of our papers is in this, where we use all 3 approaches. So the complication rate really increases when L5S1 is included. So for the entire series, the complication rate was 28, but considering only patients with L5S1 inclusion, the rate went up to 31%. Same went from 11 to 15% when an L5S1 was included in patients of the paper from Woods, and it went from 7 to 9% in patients for She. Abed-Rabo had almost 59% complication rate. Now, these numbers vary because everyone reports complications slightly differently. Like Tenori's paper had only surgical complications included, and She's paper had excluded all approach-related complications. So they're not similarly measured. So that's why there's a wide variation of these numbers. The main worry with these approaches are vascular injuries. They are either major or minor. Major is an injury to aorta, IVC, or the common iliac vessels, while minor injuries can be to the iliolumbar veins or the segmental vessels and so forth. So major complications were none, fortunately, in our series. They jumped from 1.5 to 2.1% in the series by Woods. And the total complications jump from 2% to 5% in our paper, and they jump from approximately 3% to 4% in Wood's papers, and so forth. So there's a definite jump in the risk of complications when L5S1 is included. And that's true even for prolonged paralytic ileus, jump from 4 to 5% or from 3 to 3.6% and so forth, almost up to 6% in Abedravo's paper. Groin pain or anterior thigh symptoms like numbness or pain or sometimes even weakness of the iliopsoas is common with the OLIF approaches. And that's because of the amount of retraction that psoas might require. And that tends to be higher when L5S1 is included. So it jumped from 3.5 to 5% in our series. And in the series by Shi, it jumped from 15 to almost 20% when L5S1 was included. Lastly, subsidence, as we talked about, the blind preparation of L5 inferior enclave. I think that may have a contribution, as was reported, a jump from 4.4 to 6% when L5S1 is included in terms of subsidence. So these are the complications. So lastly, L5S1 inclusion in OLIF or ATP is challenging. There is a definite learning curve that goes with it. I think it's always safe to take the help of an access surgeon, a general surgeon or a vascular surgeon within your institution, at least for the first few cases, to kind of understand the anatomy and get used to these approaches and staying safe from complications. But overall, if you're able to include L5S1, OLIF, and ATP, it makes the approach much more versatile, and you can include a lot more patients with this approach. So that's my talk on L5S1 OLIF. Thank you so much for listening.
Thank you, Chirag. Fantastic presentation, and congratulations for your paper. Just a few questions. Chirag, how many patients did you have for your study?
So our study had about 87 patients, and patients that included L5S1 were 19.
So just my doubt about, in the paper that you quoted by Woods, there's almost 5% risk of vascular injuries, right? So why not a posterior approach? Because you're approaching the disc space from anteriorly. So why not from a traditional posterior, and you avoid the problems of vascular injury? Is it because of the trade-off between achieving better fusion versus vascular injury?
Yes, so if you're going posteriorly for L5S1, your options are to do a TLIF or transforaminal interbody fusion. Now, those cages tend to be much smaller. They have a smaller footprint. And because you're going from the back, you're not able to open up the disc as well and create the lordosis. And because it's a smaller footprint, there may be a higher risk of subsidence because there's not a whole lot of support that you can give the end plates. Now, I do end up doing a TLIF in some patients if I'm not able to safely approach L5S1 from the front. So that's where you kind of have to pick and choose what's safe, and at the same time, the convenience of being able to use the same approach for all levels will just save on the operative time. If you're doing OLIF and ATP for all levels up to L5, and then just for L5S1, you have to spend a lot of time with the TLIF from the back, it just increases your operative time significantly, because at each level that you do a TLIF, it's not similar to the OLIF. With the OLIF, everything is in front of you. So you save a lot of time going from one level to the other. But for TLIF, each level has a separate number of hours that you have to give. So it's just a much longer surgery if you're doing a posterior technique for L5S1, but an anterior one for the approaches. So having the ability to do everything in the same position for the patient and being able to put a larger cage at L5S1, I think those are the biggest advantages for OLIF at L5S1.
So one of the biggest advantages should be reduced operating time and hence the risk of infection as well.
Correct, absolutely. Abdominal surgeries tend to have a very low risk of infection, and you don't have to put a drain or anything. Amount of blood loss is very, very minimal just because you go through fascial planes. You're not cutting through any muscles. It's a muscle splitting approach. So all those advantages really make it minimally invasive and low risk of complications.
And are you able to do those really, I mean, what do you say, the miss approach using tubular retractors for OLIF? Is it technically possible for this particular area, alpha S1? Like how
I
you do
would
in the
say,
XLIF or the extreme?
right. I would say they look risky to me. I don't use those tubular-based retractors. And even the description of OLIF by the Dr. Wood's paper describes that for 5-1 they would use the retractor blades rather than using the tubes, just because the vascular anatomy is so critical there that you really have to use your retractor blades with good amount of tactile feedback to be able to retract those vessels in a very safe manner. So using tubes at L5S1 is going to be very, very difficult. I know certain surgeons do use them and they're comfortable with it, but I think that's going to be just a complication waiting to happen in a lot of patients.
And do you use any biologics to enhance fusion for your OLIFs?
I personally do not. I use bone marrow aspirate from the patient's own vertebral bodies and mix it with allograft bone chips. I've occasionally used DBX or demineralized bone matrix in a putty form if I'm not able to get good amount of bone marrow. I know individuals have used things like Vivigen, and lastly, BMP is also always available. I think it's a good option to guarantee your fusion with BMP. BMP is known or kind of infamous because of its risk of injury to the sympathetic plexus L5S1. So you may have to worry about it in younger male individuals and so forth.
And is it still available? Because there are a lot of issues with the infused trial, isn't it?
They are available, and they may be a good option for patients with osteopenia, osteoporosis, or prior history of pseudoarthrosis if they're smokers and so forth. And I believe a lot of the systems have that as they can be used, and they have been approved to be used with certain one of these OLIF gauges and so forth.
Okay, thank you for that, Chirag. I think that's all the questions that we have for this session, Chirag. Fantastic lecture. And once again, congratulations for your wonderful paper. And we really look forward for more lectures from your side. Thank you very much for joining in.
Thank you so much. Thank you for listening. Thank you for having me.
Bye-bye.